Hi, I'm Dr. Joseph. I'm a radiologist. So today we'll be starting a live session on some few questions on radiology, most common radiology questions you can, expect in the coming years. So we'll start with the first question. That is question number one. A clinical suspicion of acoustic neuroma is made and an MRI is ordered. Which contrast agent is most commonly used in MRI for diagnosing acoustic neuroma and why? First option is gadolinium-based contrast agent due to its high sensitivity in detecting small tumors. So I would straight away go ahead and take this as correct answer. Why the others are just iodine-based contrast agents, barium sulfate, paramagnetic agent due to its high ability to detect highlight vascular structures. So I would mark this as the correct answer. You know why? Because you know for sure that MRI uses gadolinium as contrast agents, and iodine-based contrast agents like iohexol is used in CT, right? And barium sulfate, BaSO4. Where do we use that? So we use that in barium swallow, follow through, such when you want to opacify the bowel is when you use barium most commonly, right? Then paramagnetic agent, that is option D, due to its ability to highlight vascular structures, it's very vague compared to option A, which is gadolinium based contrast agent. Okay, that's a correct answer. So answer is gadolinium based contrast agent due to its high sensitivity in detecting small tumors. So I'll show you how sensitive it is. Okay, so I have an image. So this is a T1 contrast enhanced image. So you can see that everything looks all right here. So this is the posterior fossa. Okay, can you see a tumor right here? Right. So this is because we are using gadolinium. Okay, so I'll get back to the tumor again. So I'll just draw the tumor for you. So what do you think this is? It's an acoustic schwannoma. Why do I say that it's an acoustic schwannoma? Because it has got an ice cream shape appearance. Okay, so ice cream cone appearance to be precise. Okay, looks like an ice cream cone because the majority of the tumor is outside the internal acoustic canal, which is big, and as it extends inside the internal acoustic canal, it becomes narrower because it follows the eighth nerve, seventh, eighth nerve complex. Okay. So now we have this image. You know, ice cream cone appearance is seen in acoustic schwannoma. Now I'll show you another one. What if you have a similar tumor here? What if you have another ice cream cone here? You can straight away go for NF2, neurofibromatosis 2. But that is one of those phakomatosis where you get one of those multiple conditions where you get bilateral acoustic schwannomas, which are like pathognomic of NF2, okay, neurofibromatosis 2. All right, so we'll move on to the next. So what is this? This is a movie, it's a scene from a film. So this is what happens when you go to the MRI room. Okay, so some of you would have accompanied patients during internship into the MRI room. So you may have noticed that there's a large magnet right inside the MRI room. So it's a door here. You'll be shifting the patient inside on a trolley, right? So what happens? So you should know what happens when you enter the MRI room and for precisely when you enter this gantry, right? So all the protons inside your body, right? It gets aligned to the magnetic field of the large MRI bore magnet, right? So just draw it here. Okay. So this is large MRI bore magnet. The whole thing is a magnet. Okay. So when you go inside, all your protons gets aligned either parallel or anti-parallel. Okay. To the magnetic field, right? So that's why we have magneto turning all the missiles into one direction, right? In this image. Okay. So this is a magnet and this is all your protons. All right. So before you enter the magnet, all your protons are going haywire, somewhere here, somewhere there. So it doesn't have any purpose or any direction. Okay. So once you get into the MRI magnet, we have not even started the scan, right? Just after you enter the MRI magnet, all your protons get aligned. So next thing is, the next step which happens is your protons not only gets aligned, it also rotates like a spinning top, right? Like a spinning top, it rotates. Okay, it rotates. So it rotates at a very high frequency, right? Very high frequency, proportional to the Tesla. That is a power. So you might have noticed there's a 1.5 Tesla, there's a 0.5 Tesla, there's a 3 Tesla. It just indicates the power of that huge magnet that you see inside the MRI room. All right. So these protons keep rotating like a spinning top, like you see here, like you see here, here. Okay. It keeps rotating at a very fast rate. So if you have played with a spinning top before, if you just give it a small tilt with your finger, it comes back, right? So same thing happens. So when you go to the MRI room, you might have, after you shift the patient inside and you come back towards the gantry, you may hear like huge sounds like tag, tag, tag sounds inside, right? Those are the gradients. Those are the RF pulses which goes inside and tilts these protons, which are spinning like a spinning top, out of its axis, and it comes back, right? So now the time it takes to come back is your T1, right? So T1 and T2 are nothing but time, relaxation times, and T2 is a different concept, but it is also a time. Okay. So now we come back to the spinning tops. If you see the spinning tops, all of them are not similar. Okay. So similarly, all of the protons inside your body may be inside fat, can be inside protein, can be inside your skin, right? So they're all not same, right? They are different tissues, so they have they are different tissues of different composition. So all of these spinning tops, if I give a same tilt, so I just remove those. Yeah, if I give, so imagine these are all spinning, right? If you give a small tilt, it may come back in 0.1 seconds. If I give this a tilt, a small tilt, it may come back in 2 seconds. Depends on how it is made, right? So it depends on how your body composition, I mean the tissues are, right? So now this is the RF pulse, which is the tilt which you give to the spinning top, and it comes back. You measure the time. Okay, you measure the time. See who comes first, right? So here in our body, fat comes back first. So it comes back very shortly after you give that pulse. That's a RF pulse. This tilt which you give is a RF pulse, right? Comes back fast. So it's a short T1. So fat has a short T1. Okay, it means the protons inside the fat comes back faster, right? Now the other spectrum is fluid. It takes a long time to come back. So now the machine, the computer, sees which comes earlier and assigns a brighter signal to the short T1. That is the reason why fat, I'm showing you the subcutaneous fat, is bright. See, this is the reason why I'm showing you the, see, this is dark, that's CSF, that's water, right? It's dark. Fat here is bright. That's subcutaneous fat. Make sense? So that's the reason why we see a good T1 image, because of difference in the time it takes to come back to its original axis of spinning, right? So T1, T2, I mean, I talked about T1, T2 is also something similar. Okay. Now, what are the MCQs they can derive from this concept? Now they can ask a question like, what is the meaning of T1? They'll say option A will be intensity. Or you can, they can ask what is the uh, physics behind T1? Okay, what do you measure as T1? They say intensity. Most of you or me during coaching, I mean during my NEET PG time would have fall for this intensity. And sometimes it'll be like bright, distance, time. Now this is the correct answer, right? This is the correct answer, time. So this is why I told you this whole concept, so that you know T1, T2 are just time, right? So this is the MCQ which you can or anybody can derive from this concept, right? So we'll just go back. Yeah. So once you have this, some of the tissues like fat is short T1, something is long T1, right? So they have a contrast between them. This may be dark, this will be white. And difference between this white and dark, that's what makes an MRI image, right? So this is just a graph which depicts that time of fat and H2 are different, and T2 also, relaxation times are different. Okay, this is an important concept I wanted you to understand, right? Now this image will make much more sense to you, right? Now you see that the fat of T1 is here. It is bright because it has a short T1. It takes less time to come back to its axis, right? Now this is CSF. It is dark, right? Because it takes a long time to come back. Now this is a tumor in T1. So tumor is soft tissue. It comes in between fat and water. So it has an intermediate intensity, like it's like a gray color stuff here, right? So now you want to make it bright. So you give contrast, right? You give contrast because contrast has a short T1, and the tumor will take up contrast. When you do an MRI with contrast, tumor takes it up, and the contrast in the tumor will make it bright. Okay, so I'll show you. Even now, this is T1 fat set images because we have suppressed the fat. Fat is all dark now, right? Tumor is also dark. Okay, but once you give contrast, you are injecting a short T1 pharmaceutical inside the tumor, right? It preferentially takes up in the tumor, and now you see T1 with contrast is super bright. Yeah, but this is why we use gadolinium, because it has a short T1. Another MCQ, why we use gadolinium? What is the physical principle? What's the physics behind using gadolinium? Short T1, short T1, short T1, right? It makes it bright. Computer analyzes short T1 as bright. All right, always remember this. Okay, so again, I can draw an ice cream cone here, right? Again, I'm telling you, if you see another ice cream cone, go for NF2, right? So I'll just show you 7th and 8th nerve complex. So this would be the 7th and 8th nerve complex here. This would be the 7th and 8th nerve complex on the contralateral side. So you can see that the tumor, the acoustic neuron, actually extends inside the acoustic canal, right? That gives you the cone of the ice cream, right? So we'll go back to we will go to the next question. So other, MCQs which can be derived from this question will be identify sequences. We'll go to that later. High T1 signal is because of short T1. Now you know it better than me, yeah? So some things which they can ask from this question, from this image, is that to name, this is cerebellum, this is the ice cream cone, then this would be the pons. Okay, this is the fourth ventricle. It's all mentioned there, fourth ventricle. And these are the important things. Okay, rest of it's okay. I don't think they'll ask. It's a temporal lobe. Yeah. So now we'll go back to another one. Okay. And one more thing in this question. Can you see this? This is sinus. This is sinus, one of those sinuses which can get blocked in CVT, cortical venous thrombosis, right? If you see some filling defect here, you can call it a CVT, right? So these are the things which they can ask from this image, right? If they give such an image, you have to look for these things. Okay, you can look for tumor here. Okay, those are the things. So cerebellar tumors, that's a huge topic by itself, so I'm not going to discuss it right now. Okay, so if you get an image like this, these could be the things which they're trying to show you, right? So now we'll go to the next question. Now next is the MRS. Okay, it's quite complicated, so I'll just discuss it in detail again. So question number 2, the following magnetic resonance spectroscopy, MRS, spectrum was obtained from lung tissue of a patient diagnosed with pulmonary tuberculosis. Which of the following statement is more accurate regarding the lipid peak observed at 1.3 ppm in the spectrum? So this is something which you have to know off your head. So I'll just tell you that this is a lipid peak. Okay, so this is a lipid peak. First of all, I'll just tell you about the normal MRS before I go ahead with the this question. Okay, so just remember this is a lipid peak. Okay, and CNTB. Okay, so now we'll come back to this question after I tell you why we do an MRS. Okay, so we come back to spinning top. So I keep the same spinning top in different environments. I keep this in clay, I keep this in mud, I keep this in water, I keep this in air, I keep this in fire, whatever. So the environment in which the spinning top is determines the way it spins, right? So if you keep in clay, it just, it doesn't spin so long. If you try to spin it in water, it doesn't spin so long. So MRS basically is a sequence. I mean, you can say it's a sequence, or it's a property of protons to get influenced by the surroundings with a strong wind, and it affects the spinning top, right? So you can identify molecules by identifying the spin of that proton in a particular molecule. That's mind-blowing sometimes. From an MRI sequence, you can know which molecule is more in a brain tissue, right? So we'll come back to the question. Now you have something called lipid, right? So the correct answer is it reflects necrosis and tissue breakdown due to chronic infection. So this is actually simple terms, TB, right? So we'll see why TB can cause lipid peak. Okay. So we'll come to a normal MRS first. Okay. This is also very important because if they can ask about lipid peak, they can very well ask about normal peaks. Okay. So first thing is NAA is a normal neuronal marker. N for neuronal marker. Okay, it's a normal neuronal marker. If there's anything which affects the brain, it will go down. That's it about NA. Okay, that's it about NA. Any insult, be it infarct, tumor, infection, there's no normal neural tissue there, NA is going to go down. Okay. Next is, so NA is neuronal marker. Any insult will reduce NAA. Okay. Next is creatine. The creatine you'll be familiar. A lot of people who goes to the gym will be taking creatine as a pre-workout. Why? Because it is a high energy phosphate. Okay. Because it's a high energy phosphate. Now, it's just used as a reference value for comparison of the going up and coming down of the other molecules. It itself doesn't have much significance. Okay, but it's a normal, MRS molecule. Okay, so that comes here. Okay, Na. Then next one is choline, very, very important. Okay, next one is choline, is very important. I'll show you why. Choline is a part of your cell membrane. Okay, any living tissue, especially, we're talking about brain right now, undergoes constant replacement, be it your skin, be it your brain cells, whatever. Okay, constant replacement, and this metabolic turnover. Now the cell membrane, when it breaks down, releases choline. Okay, so if there is a normal replacement of tissues and normal breakdown of tissues happening, as in case of any person or any tissue, choline will be there, as baseline here. Okay, now we'll go back to why it will be elevated. If you have a tumor, what happens there? It's a high cell turnover. It's a lot of breakage of tissues. A lot of breakage of cells, be it any cell. It's a huge release of choline because the cell membrane keeps getting broken down. High cell turnover causes increased choline. Okay, so if you have a glioblastoma multiforme GBM, now it is replaced as WHO grade 4 tumors. Okay, so high grade astrocytoma, that's also replaced now in 2021 WHO nomenclature as grade 4, high grade gliomas. Okay, so bottom line is, if you have a high choline, right? High choline, it just means there's a high turnover happening of cells. That means it's a tumor, likely a malignant one, mostly a malignant one. Okay, so choline is increased in tumors like glioma, especially the high grade ones. All right, so now we'll go back to the lactate doublet. So now lactate, I want you to understand that lactate is not a normal thing. Okay, we don't have lactate in our body normally to a high level to detect. When we run, we get muscle cramps because of lactate. Yeah, so when there is a high, high energy metabolism happening, there will be lactate accumulation. But in tumors, because of the Warburg effect, glucose, because of glycolysis becomes pyruvate, then becomes lactate, right? Now, lactate, it's very easy for you to identify lactate because it's a doublet. All right, so that's a doublet here. Okay, it has two peaks. It's one of the last ones. Okay, so you have NAA, you have creatinine, you have choline, right? So lactate is one of those last peaks, but it will have a doublet, look like an M. All right, so we went past lactate. Next, one of the last things is lipid peak. Now I want you to understand one thing. So in abscesses, even in glioblastomas, even in things like caseous necrosis, lipid peaks will be high. Okay, so this is one of those peaks, lipid peak. We use it mostly for TB, this caseous necrosis. So lipids will be there. This is a lactate doublet. Now understand that this MR is usually used when you have, glioma versus infection, or TB, So glioma will have a high grade glioma, will have high choline, right? And infections like TB will have a high lipid. So something to keep in mind, simpler terms. Okay, so bacterial abscess, not very commonly used, but just know that it will have lactate, alanine, cystosolic acid, and acetate are elevated. Okay, so Na being absent is a perpetual thing in any pathology affecting the brain. Okay, so we'll come to the next session. Next question. Question 3 is 35-year-old male presents with progressive neurological symptoms and an MRI brain is ordered. The MRI reveals a lesion with high signal intensity on T2-weighted imaging. Which physical principle is responsible for the contrast observed on T2-weighted images? You know this already. We explained. It's a T2 relaxation time. It's done. We already explained this. All right. Since they asked about T2-weighted, we talk about T2 relaxation time. All right. The same image which we had gone through before. Next is a 45-year-old woman with a history of total hip replacement due to osteoarthritis and a 10-year-old child with a cochlear implant for hearing loss are scheduled for MRI. Which of the following is an absolute contraindication for MRI? This question needs some explanation because now we have option A, both hip replacement and cochlear implant are contraindications. B, only hip replacement is a contraindication. C, only cochlear implant is a contraindication. D, neither hip replacement nor cochlear implant are contraindications. Now, I just want to tell you that right now, we can, in these options, we only have cochlear implant, which is like an absolute contraindication. But thing is, even any medical devices right now, I'm talking about current phase, they're all made, they all have at least have a version which is MRI compatible or at least MRI programmable, right? Which can be programmed so that MRI can be taken safely or MRI compatible, right? So if you are faced with something like this question, you can go ahead and see this table. You have one set which is cardiac implantable electronics, which are absolute contraindications. Other absolute contraindications are intraocular foreign bodies, implantable neurostimulators, cochlear implants, implantable drug infusion devices, Intravascular catheters with metallic components, Swan-Ganz catheter, metallic foreign bodies, bullet shrapnel, cerebral artery aneurysm clips, and magnetic dental implants. But very important, and another thing is relative contraindications: coronary stents, programmable shunts, metal airway stents or tracheostomies, intrauterine devices, ocular processes, tapered implants, surgical clips or wire sutures, joint replacements, IVC filters, Harrington rods, tattoos less than 6 weeks. Now it's an extensive list, right? It's an extensive list, but I want you guys to keep in mind one thing, that almost all medical devices, be it um, you know intracranial aneurysm coils, they all made MRI compatible now. They all have an MRI compatible version. Okay, so if faced with options like, sorry, yeah, if faced with options such as this, yeah. So I'll just delete all the previous ones. Okay. If faced such a question, what you do is, yeah, yeah, all right. If faced with such a question, you can do always see for these first: metallic foreign bodies, bullets and shrapnel. They don't make bullets which are MRI compatible. Okay, they don't make shrapnel which are MRI compatible, and but they do make medical devices MRI compatible now. So in effect, you know, the most current situation, the only absolute contraindication will be metallic foreign bodies, right? Because others are made MRI compatible now. Okay, so if you do have options like three options from here, sorry, um, yeah. If you have options like three options from here, and one option from this, you can click this as the absolute contraindication. But if you have three options from here, say, even foreign bodies are absolute contraindications if it's metallic. Implantable neurostimulators, cochlear implant, drug infusion, and then you have another option of metallic foreign bodies or intraocular foreign bodies. I will always go with this. Because others may be MRI compatible depending on what type of, stent or, catheter they have inserted. So finally, practical purposes, we always ask when they call from MRI room, they always ask to get the, discharge summary or the manufacturer's manual to see the situation of the stent is MR compatible or not. All right. So this is something which I told right now. Okay. So because a lot of competition in the market for medical devices, they're all trying to make it MRI compatible. Okay. So yeah. So what if you do MRI? Okay. Just say you take a risk, you don't know what it is, and you take an MRI. What happens? So what is Magneto doing here, right? He's just twisting the missiles. Same thing happens. So it can, first of all, malfunction, can damage. Okay, it can even twist and finally displace and cause damage to the surrounding tissues. So all these can happen. Okay, so if you're not sure, better not to do it. Get to go for a CT, right? So that's about that question. Now, next is a question 5. 34-year-old female presents with symptoms of deep vein thrombosis in her left leg. Duplex ultrasound is ordered. What does duplex in duplex ultrasonography refer to? Okay. So the correct answer is combination of beam mode imaging and Doppler flow assessment. Okay. So you should know that. I'll show you an image. Okay. So what you see here is the B mode. There's a normal ultrasound mode, B mode. Only you see a lot of gray and white, whatever. Now, when you on the Doppler, you see one on the Doppler, you will see this box. So for you to know in the exam whether it's a Doppler look for this, either blue or red signal here, and look for this box. Okay, right? So this is the color Doppler mode. Okay, so makes sense. So duplex is a combination of B mode imaging, that is this, plus a Doppler flow assessment, which is this. Make sense? Yeah. So that is the answer for the question. Okay. So can you see the abnormality here? I'll just remove the annotations. Okay. So can you see the abnormality here? I'll just focus it for you. All right. There is flow in this vessel, but I'm not seeing any flow in this vessel. Okay. Even while compressing, this is not getting compressed so much, right? So this is how a thrombus will look. This is a thrombus, it's a deep vein thrombus. Okay. This is how a thrombus will look. First of all, there will not be flow, or maybe minimal flow depending on the size of the thrombus, but compressibility is another MCQs at your doorstep. Now, these are the features how you confirm a thrombus. One is you see an echogenic stuff inside the vessel. This is echogenic stuff inside vessel, right? And there is no flow, and it is non-compressible, right? This is how you diagnose a thrombus. Okay, so I'll go back. Yeah, so 3 MCQ questions right there. Now, what happens if you don't treat a thrombus or don't diagnose it? This happens. So what is this? This is a CT scan, contrast enhanced CT scan of the thorax. So there you can see this is a pulmonary artery. Okay, pulmonary artery of right side. Can you see a filling defect inside it? This is the pulmonary embolism. This is the after effect if you do not pick it up on ultrasound or clinically. Yeah. So that thrombus will get dislodged, goes up, right up into the pulmonary artery and cause this. All right. So that's why it's very important to do a Doppler and to clinically suspect in the first place. Okay. Now question number 6. 60-year-old male with a history of lung cancer presents for further evaluation of suspected metastasis. 3 nucleus scans are conducted to evaluate different aspects of his condition. The following images represent which scan. It may be very tricky, in the first image, or looks the same. So, but I would like to highlight the differences. Okay, as you can see, there is some metastasis here. Yeah, it is picked up in the bone scan and PET scan. So essentially what they're asking is which is PET scan, which is bone scan. Okay, so I would give you some pointers how to pick it up. First of all, PET works on glucose uptake, right? The parts in the body, sorry, which takes glucose the most is the brain. So just first look at the head. Okay, so dark signal actually means high signal, right? High pickup of the tracer, high accumulation of the tracer. Now, by this itself, I can confirm that it's a PET. And bone scan, this is technetium, MTP. So now that will not be taken up by the brain. Okay, but PET, so F18, which is tagged to glucose, should be picked up by the brain and even by the bone marrow to an extent. Okay, so that's why the bone marrow, the vertebrae is also showing quite a bit of an uptake, right? Bladder excretion is there in both, so that you cannot use it to differentiate, right? So now you can understand that this is PET because of the brain. This is the bone scan. You with me? All right. So next, so the answer is A is bone scan, B is PET. A is bone scan, B is PET. Okay. So now I want to introduce you to something called super scan. Okay. So so you take a break for this question. So we were talking about super scan. So first we will show differences between PET and bone scan, which we just discussed. So even without all these pointers, you will be able to differentiate between them because PET has a brain, bone scan doesn't. Just remember that much. Okay. So PET is showing brain uptake. All right. Now we'll go to something called super scan. It's very important and very simple concept. Okay. And very high yield, I feel. So super scan is imaging appearance of technetium-99 bisphosphonate bone scan occurs as a result of high ratio of bone to soft tissue tracer accumulation because of intense osteoblastic activity in the bones, which causes diminished renal and background soft tissue uptake. I'm sure you will understand. Okay, I'll just show you how. Okay, and we'll come back to this after that. Now, this is a normal bone scan, except that just forget about this tibia. That's pages. Just forget about it now. Okay, this is a normal bone scan. Okay, so I'll just zoom it up for you. You can see that there are some, areas of uptake in the bladder. Anyways, because it's straight in the bladder, so it's fine. Yeah, that's normal. There are a few uptake here, here. The shoulders. It's completely normal. Okay, do not call them as metastasis. This is a normal PET scan, except for the tibia. Okay, so just forget about this tibia and then concentrate on the other places. Okay. So all these small uptake, what you see here, here shoulder, they have some shoulder can have some osteoarthritic changes, all those things, just normal. And this is also normal. Okay, this is where you inject the tracer. Okay, so keep this in your mind as a normal bone scan. Right now, so that is why I was talking about degenerative pattern of uptake in spine, shoulders, and left first MTP joint is all there. Okay, so degenerative pattern is fine. Now I'll just show you, this is also a normal bone scan. Okay, this also is normal bone scan, and there can be some uptake right here, here. It's totally normal. Okay, totally normal. Now I'll show you something else. Now see this, compared to the previous one, it looks like somebody has painted the black ink, right? This is super scan. Okay, what you see right here is super scan. Okay, that means that's intense uptake. See, it's so black. You can see the areas of bone marrow, the calvarium, the ribs, the clavicle, the pelvis, vertebrae, yeah, sternum. These are areas where an adult can have bone marrow. They're all picked up so well, right? Now, this is a super scan because of METs. Okay, and another subtle difference which I want to tell you is that, are you able to see the kidneys anywhere? I'm not able to see the kidneys. Yeah, there's no uptake in the kidneys, while the previous one, okay, the previous one had slight uptake in the kidney. The previous one is a normal one, right? Slight uptake in the kidneys. Now the uptake is so much in super scan that it doesn't give anything much to the kidneys to excrete. It just accumulates in the bones. All right, so that is the reason of this super scan in metastasis. Now super scan is seen predominantly in two conditions. One is metastasis, like a diffuse metastasis, and also in areas, in conditions where there is, hyperparathyroidism, any metabolic conditions. There, the difference of super scan is that they'll have more of a limb uptake, right? So limbs will have more uptake than the axial skeleton, right? So this is a metabolic super scan. Metabolic super scan. Both are diabolic, but this is a metabolic super scan. Okay, both are really bad. Okay, bad for the patient. But this is even more bad because it's meths. All right. So now we'll go to the next one. So now shall we read the previous statement again? It makes sense. Okay. Super scan. A super scan is an imaging appearance of technetium-99 bisphosphonate bone scan, which occurs as a result of a high ratio of bone to soft tissue. So thing is, even the soft tissues were showing uptake, right? I'll just show you soft tissue. See, even these calf muscles here, showing uptake. But if you see our super scan, it is not giving tracer to any of them, right? It's not showing any uptake anywhere. It doesn't give to the kidney, it doesn't give to the soft tissue. So it's a high ratio. That's what they mean by high ratio of bone to soft tissue tracer accumulation. And intense osteoblastic activity in the bones causes diminished renal and background soft tissue uptake. Makes sense, right? Now, very important thing. This is required for bone scan to have, for bone scan to pick up lesions, right? Intense osteoblastic activity is required. Some lesions can be bone scan cold because they can have multiple lytic lesions or sclerotic lesions, whatever. But if there is no osteoblastic activity, there will not be alkaline phosphatase. That's a different story altogether in the serum, but bone scan will be cold. Okay, they won't have that uptake. So example of that is cold scan. A nice blue color is seen for cold scan here. So multiple myeloma, sometimes even RCC metastasis, this can happen, right? So keep this in your mind. Okay, you cannot just say, yeah, bone scan is negative, so no uptake, so there's no medicine. Always see what metastasis are you talking about. If it's multiple myeloma, multiple myeloma is not metastasis, it's just primarily bone lesion, RCC. Okay, always have that in your mind, all right, before you call anything as a negative bone scan. Okay, keep this in your mind. This can come as a MCQ. Technetium 99 methyl diphosphate. Okay, so bone scan tracer. Okay, now we'll go to the next question. Question number 7. 35-year-old male presents after a diving accident where he struck his head head on, right? A cervical spine CT scan reveals a burst fracture of the C1 vertebra with lateral masses displaced outward. What is this injury called? It's a trivia question. Just have to know what it's called. But we'll try to remember based on the mechanism. Okay, so here is your body. This is the head. C1 is a single vertebra which just holds that, that turning of your head, extension, whatever. It's just a ring-shaped vertebra, right? C1, it has arches, the morphology itself of C1 is so different than the other vertebrae, just like a ring. Okay, so if you see this CT image, you can see multiple breaks in that ring, right? In the anterior arch and also in the posterior arch. And once it breaks, right, this is the odontoid process. Okay, this is the odontoid process of C2 odontoid, on which C1 does all the circus, right? So this is the odontoid process of C2, this pen, C1, and once it breaks, okay, and this odontoid process held by this one transverse ligament here, okay, yes, like this, and then once it breaks, this C1 goes away from the odontoid. Yeah, I'll tell you why it's so important. Okay, so this is called as Jefferson fracture to begin with. What we're talking about, C1. So this is Jefferson, I think he's president of America, previous president. So most important thing is mechanism of injury. You go head on and collide. You try to dive from a distance and you misinterpret the shallowness of the depth of the ocean or whatever. You go head right on. And also rugby players, or diving into a shallow pool. Now that's when the axial load just compresses and just breaks C1. Okay, so we told that there's a transverse ligament here which holds the odontoid process of C2. This is C1, 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 C1. Okay. So now there is a anterior displacement. Okay, this part is anterior arch will go displaced like this, right? Now that is the reason in a lateral cervical X-ray, yeah, you see that this distance is increased. Okay, so AAD, Atlando axial distance, is increased. Okay, so because this anterior arch is displaced anteriorly. Okay, so anterior displacement dense is the same. This is C2 vertebrae. This is part of C1 anterior arch. All right, makes sense? Yeah. So that is why in C1 fracture there will be increased AAT. Okay. So now come to hangman's fracture. This do not be confused with the whole image, just remember this. Okay, this is the pars inter articularis. Just remember this alone from this image. Okay, of the vertebrae, like one bridge between the anterior, of this pedicle and the rest of the posterior spinous processes. Okay, so it's like a bridge. So what happens is that hangman's fracture is a pars fracture. Remember, it's a pars fracture. Sorry, mechanism of action is if a person's neck becomes like this, hyperextension, right? Hyperextension happens in prolonged hanging, hanging as such. So, or if you try to park your car against a wall or a truck without using brakes, this also can happen. And your head will go against the windshield and tries to extend it so much that this happens, right? Now this go and break it. The pars is broken. So that is the reason behind. So the behind the hangman's fracture. So what you have to understand, it's a hangman's the pars intraarticularis fracture. Okay, so that is done, and that's a C2. Yeah, the one which you just saw, the axial loading in Jefferson, C1. This is C2. Okay, Jefferson hang. Okay. Next is burst fracture. Is very easy. If you have an axial loading, something falls on you and then one of the vertebrae gets compressed like this. Okay, it's called a burst fracture. Just very normal mechanism, and you can see that in AP thoracolumbar spines very difficult sometimes. So I'll just show you. This is the vertebrae. This is a vertebrae. Can you see that there is less height of this vertebrae? Yeah, this less, which is very much seen on the lateral film. Okay, this is the fractured vertebrae. Very important thing is look for the retropulsed fracture fragment that can actually cause spinal cord injury, right? So that's something which you have to be careful when you see a fracture like that. Clay-Shawlers fracture, nothing much. I just want you to remember that it is this. Okay, it's a lower cervical vertebrae, spinous process fracture. Okay, that's it. It was discovered in old Australian coal miners. It has that kind of a history. So that's about it. Direct blow, motor vehicle accidents, subtle muscle contraction. You shovel clay, a subtle muscle contraction here that can, break the spinous process. So that's simple. So next, question number 8. A 60-year-old smoker presents with cough and shortness of breath. A chest X-ray reveals dense consolidation in the right lower lobe with visible air-filled bronchi traversing through the consolidation. What is this radiological sign called? Very simple. Air bronchogram. I'll just show you why. Okay. So if you see a chest X-ray like this, okay, you can see that there is an opacity here, right? And you can see that there was some lucency is going towards it like a tree, right? Like a tree. So air bronchogram, because air is in between the consolidation. Okay, a hallmark of consolidation, right? So what happens on a CT? So you see a lot of X-ray, and very difficult for you to make out what you're trying to see. Just see the CT of it. Okay, CT is much more clear. This is a whole consolidation right here, and these bronchi are just coursing through it. If you take an X-ray, do an X-ray of this, X-ray rays will come like this, and then you see a CT equivalent of it is this, right? This is air bronchogram. Try to pick this up in the spotters, whatever you get. All right, it's very important. So somebody has drawn again. Okay, look for this. Okay, now next option was Silhouette sign. Let's go back to it. Silhouette sign. Okay, so silhouette sign is nothing. Okay, so if I keep two fingers like this, right, or like this, and if you pass light through it, you can see both of them are separate. If I am close to it, right, if you pass light, you won't be able to see the difference between them. That's essentially silhouette. Silhouette meaning the shadow of these two will be different. Now the shadow of these two will be in. You won't be able to differentiate between them. Yeah, that's all. Indistinguishable. Yeah, that's what I'm trying to say. So it's like two people are trying to, you can differentiate the coffin or, I mean, whatever table from this guy, but you can't differentiate from this guy because there is a silhouette effect of this box and the guy's back right here. Okay, that is silhouette. Now, I'll show an example of it. Right middle lobe is in contact with the middle mediastinum. Okay, so the right middle lobe consolidation, so say this is mediastinum, this is the right middle lobe. They are in contact with each other. When right middle lobe pacifies, you won't be able to differentiate both of them. That's precisely what is shown here. So this was a right middle lobe here, likely, and when it opacifies, you are not able to differentiate between them. Still outside. Solve. Okay, that's about it. So go to the next one. It's curly lines. Okay, so it's a very important concept which I would like to explain. Okay, just bear with me for 3 minutes. Okay, so now curly lines is nothing but interstitial edema of lungs, aka pulmonary edema. All right, clear? Now I'll show you how lung bronchoalveolar segments are made of. I mean, not bronchoalveolar segments, pulmonary lobules are made of. Okay, so now they're all like this. Okay, like this. Another one here. Okay, so you have a lot of things. So you have this interstitium. This would be the interstitium, right? So now there is interstitium and also some lymphatics going through this. Okay. Now this pulmonary edema, this imagine edema of your limbs, right? If you have edema of your limbs, the interstitium, I mean, there's a lot, you can see some facial planes, getting water accumulated or the tissue is getting water. Now what happened? That is a normal tissue here. If you have a cellulitis or whatever, or a CKD. Now in lungs, what happens is interstitial edema will be here. Okay. If there is pulmonary edema, there's a lot of water here, right? This becomes more visible and have another bronchoalveolar segment here. Okay. Suddenly, when you pass an X-ray, it becomes here. So if you take this out, it becomes a line. That's your curly line. Nothing else. Okay. So depends on where you see the lines. It's just A, B, C, D. That's about it. Okay. So now A is the orange one. Okay. So let's try to get orange here. 1 minute. Okay. All right. No problem. So now A would be the orange. Sorry about that. I'll just use the red for now. A will be the orange. So curly A lines is in the center, okay, in the central part, okay, around the hilum. C will be in the C will be in between. Okay, C is in between, which doesn't reach the pleura, and B will be it's perpendicular to the pleura. That's about it. Curly is over. Okay, so now this is a typical radiograph with curly sign. You can see that if I just expand, I mean, if you just zoom in, you can see multiple areas where you can see, lots of, lines. See? So sorry about that. Let's use a thinner version. Okay. Lines here, just, yeah, so many lines. Okay, these are all curly lines. Now what happens? They're all very transient if you treat them appropriately. Yeah, if you identify this in your ICU, you give them the appropriate treatment, it just vanishes. Okay, just like, and after treatment, it can become like a normal radiograph. All right, so that's the change you can do with just diagnosing curlies on a radiograph. Okay, just know it's pulmonary edema. Now I want you to just look at this image. Okay, why I'm showing you this image? Because one of the options where honeycomb, okay, honeycombing of lung. Okay, so I want you to look at this option very carefully. If they can ask you as an option, you can ask you as an image as well. So this is honeycombing. All right, it looks like a honeycomb, right? I don't want to explain much further, but what you need to know, honeycomb for UIP, UIP, UIP. Okay, usual interstitial pneumonia, honeycombing. Just leave it at that. Okay, so that can be seen with all the rheumatoid arthritis, all the autoimmune diseases. Okay, so that's about that. Now come to the next question. So next question is question number 9. 20-year-old male presents with a painful mass in his distal femur. X-ray of the femur shows periosteal elevation and a triangular area of new bone formation at the edges of the lesion. What is the name of this radiological feature and what is the most likely diagnosis? Sure, you guys know. So I'll just enlarge it for you. Okay. Yes. And I'm going to draw a triangle here. Now what? Codman's triangle. Codman's triangle is something which you see in an aggressive bone lesion when it just lifts up the periosteum so much, so fast that you'll be able to see it as a triangle, like a triangle which is at the base of the bone. Okay, like here. Okay, this triangle. That's about it. And osteosarcoma is one of those lesions which can have the Codman's triangle. Okay. So it is not onion skinning, it is not sunburst. Okay, it looks like a Codman's triangle, and so that's correct answer is Codman's triangle, osteosarcoma. Now I'll just go through the options once. Okay, now if you want a typical osteosarcoma, this is the one. Okay, why do I say that? I'll just draw some sunburst. Okay, see, sunburst periosteal reaction. Okay, now I don't know if you can appreciate a Codman's triangle in this, but there's a sunburst appearance in osteosarcoma. Something I want to tell you about osteosarcoma is that few MCQs which can come from osteosarcoma. One is age. Another one is it has two things. It can be primary or secondary. Now, primary will go with this. Secondary osteosarcomas can be seen in middle age, maybe 40s, 50s, and it's because it's secondary to RT, radiation therapy. Can be because of a pre-existing bone infarct. Okay, so you should know these two things. Okay, about osteosarcoma. All right, it's not just in 10-20. I mean, primary ones come early. Yeah? Secondary ones can come later also. Okay. Next is Ewing sarcoma. Okay, now Ewing sarcoma's typical thing which they can show you in a MCQ based exam is the onion skin. Okay, I'll try to draw with this. See, now I'll take it out. Try to appreciate it. Right? So onion skin seen Ewing sarcoma, and it's usually a diaphyseal lesion. Usually a diaphyseal lesion, whereas I didn't tell about osteosarcoma, it's usually a metaphyseal lesion. Osteosarcoma can be metaphyseal. Okay, so that's about that. So we'll take a break now. Okay.